Thank you. Dear friends and colleagues, today I'd like to share my experience that I have used the concept of the flap suturing for define my DCR. And for the flap suturing, why suturing help to maintain a long-term stable epithelialized drainage. Without the flap suturing, sometimes they have the contraction of the ostium and the granulation and the scar tissue increasing. So what is the best needle? The best needle and suturing is a 6/0 white krill, 8mm, S22 and spatula needle because the sharpness is in the side and in the point. And for performing, we have to create the nasal anatomy, osteotomy very good, appropriate size. I shape or head shape is fine, but my favorite one is eye incision with the AP flap. So how to suture? And the 4 types of the flap suturing that I will share with you. The first one is the intranasal continuous interlocking flap suturing. This is an ideal flap. We can, if you be familiar with performing the intranasally, you can do the continuous interlocking flap suturing. This is 100% try to approximate the nasal mucosa and the lacrimal mucosa 100%. No bleeding, no scar tissue, prevent the SUM syndrome, and increase the comfortability of the patient after surgery. And this technique, you use two-hand technique, let your assistant sit in the opposite side, hold the camera in the lower part of the nasal cavity. So you have space enough to do the surgery. So the next one is help me in the difficult condition. If you have the thick scar tissue, contraction at the common canaliculi, very tight scar, you just make it simply in the treatment room, in the office, make injection the silicone and cut in a horizontal and try to imitate the scar tissue and flip up like a imitate like a pseudo flap and use a forehand suturing and then to the lacrimal mucosa and backhand suturing for the nasal mucosa and approximate efficiently. Because if the patient sits upright, sometimes the superior fat can come down. It can have the late contraction. At 3 months, 6 months, the failure can happen. The next one is the easy one. It's efficient for the through SUM syndrome. You need to evaluate if this case have the through SUM syndrome. You just wake a vertical cord and you can see inside the lacrimal mucosa is so healthy. So this is the true SUM. Just make a simple one in the incision and rotate backwardly and just one simple. So that one gonna help for revision. So the last one, isolate anterior flap suturing. This is a tough one. It's a more challenging one. They have the 5-time failure, so we have to do the 6th time with 45 up and down. We see that the previous surgeon did not a good job on the bone. We need to do the new bone job, remove the bone very good. After bone removal, we can see a lot of thick scar tissue for the whole area of the medial and lateral mucosa of the lacrimal sac. This one, we have to cut in the anterior and create the anterior flap. You can see that anterior flap is thick and have the trend to move backward all the time. If we without the suturing, they have the high percent that the anterior flap will move backward, and when the patient lie down for the whole night, they can initiate the scar tissue. So in this case, with the 1 or 2 flap suturing, or sometimes you can make a figure 8 or double figure 8 suturing to compress the mucosa that initiate the successful. So in my series, I have found that in my 700 case, without the flap suturing, that we can got 95%. To refine our success with the flap suturing and bone concept very good can increase to be 98 or 99%. So the success is not the accidental, it's architectural, and suturing provide the scaffolding for lasting cure and forever cure. Thank you very much.